The speaker for the session will be Dr. Essa Al, and Dr. Leslie Lewis will be the moderator for the session.
Dr. Leslie Lewis is a professor and HOD, Department of Neonatology, Manipal. We welcome you, sir. So we request you to introduce a moderator, the speaker for this, Dr. Essa Al Awad.
Yeah, so I think this topic is the caffeine for apnea of prematurity, and I invite Dr. Essa to start his deliberations. I think this is one of the topic. I think this is the drug which is very commonly used extubation phase, and then some of us will continue also almost 32 weeks of gestation, and a lot of controversies are there, and still some of us are using the age-old drugs, aminophylline also. So here Dr. Essa is going to talk on caffeine and the risk of acute kidney injury in preterm infants, and offbeat or commonplace. Thank you, and go ahead.
Thank you very much for this invitation, kind invitation. Thank you, Prof Manoj, for this kind invitation. I would like to congratulate you for the great work and the great effort. It's fantastic conference so far, and we have really a lot of good time. So again, I just tweaked my presentation a little bit to be attracted for this conference, and we look for the caffeine, which, as I mentioned earlier, this very common drugs now for neonatology, and it is an association with the acute kidney injury. For preterm infants, it is an offbeat or commonplace. I have no financial relationship with any commercial for this presentation. My learning objectives, they are two. I make it short because I have only 20 minutes to finish. So identify the incidence and the risk factor of early onset neonatal AKI, and explore association between caffeine administration and risk of AKI in preterm infants. So just a little bit of introduction about the caffeine and AKI. So AKI, acute kidney injury, it's frequent in preterm infant and associated with increased morbidity and mortality. And it's defined as a rapid, potentially reversible deterioration in renal function, sufficient enough to accumulation of nitrogen, what's called that uremia. It's characterized by serum creatinine is equal or more than 0.3 ml per deciliter within 48 hours, or increased serum creatinine 1.5 times baseline, or urine volume less than 0.5 ml per kilo per hour for more than 6 hours. This is very important. The slide is good. I'm not quite sure if you're using this in your institution about the staging of AKI. AKI start to really establish more in unit, which is dealing with a premature baby, 23, 22, 23, 24 weekers. We are classified for 4 stages. Stage 0, there is no problem. Urine output, it's more than 1 ml and creatinine less than 0.3. In stage 1, creatinine raised less than 0.3 within 48 hours, or increase the percentage by 1.5 times to 1 time in references, and urine output less than more than 0.5, but definitely less than 1. Serum creatinine in stage 2 is between or equal more than 2 to 2 times from the baseline, or in between 0.3 to 0.5 urine output. In stage 3, which is the severe stage, with serum creatinine rise 3 times above the serum creatinine level, and or 2.5 milli increase per deciliter, and urine output is equal or less than 0.3 ml per hour. There is a big study which is run by World AKI Epidemiology. It's called AWAKEN. It is a huge observation study, and they reported up to 30% of neonatal or premature baby at risk they have AKI. And multi-center studies and showed that ranging from unit to unit between 18% to 70%, as low as 18%, and as high as 70%. And definitely, when you look for AKI is associated with morbidity and mortality for a point in time. This nice cartoon from that study, AWAKEN study, they looking for almost like the risk factors and the outcome. And for a baby with AKI, they looking for almost 490 with AKI in that unit, which in that hospital, 2,000 patients, and 1,600 is less no AKI. And they found that odd ratio for mortality is quite high in AKI patients and with longer hospitalization. They identify also risk factors like sepsis, aminoglycoside, prematurity, small baby, HIE, all this one associated with high risk. And they found some other risk when they have twins, the cesarean section, they have lower risk. So again, before we start, we have the caffeine, and when I started my residency, we don't have caffeine. We have only methylaxanthine, theophylline, and aminophylline, which is they work through V1, through the via A1, A2, A receptors, and that make the baby, prevent him from to have apneas and other problems. And that A1 receptors found in the brain, heart, GI, and kidneys, and even respiratory system. The initial clinical trial, because that's caffeine at that time is not found that theophylline and aminophylline is suggested that prevent AKI. So how they do that? Because as you know, with the anti-agonist for receptors A1 or A2A, they increase the flow through the kidney, and they are diuretics. They help and improve perfusion to the kidney. Then later on, a few studies suggest that caffeine administration, they do the same effect because caffeine is methylaxanthine, and they have the same effect to preventing AKI. So initially, I don't, before jumping to the caffeine study, I just like to share with you some of the theophylline and aminophylline, as they are methylaxanthine, and when they use it for birth asphyxia or other issues, and prematurity, they prevent from AKI or decrease the incidence of AKI. This study is a multi-center trial study, and they did systemic review and looking for the outcome of the theophylline and aminophylline with AKI. So they shared between all this baby receive aminophylline and to compare with non-receiving aminophylline, and they look for mid and midline, and they found a randomized control study. They found almost 6 trial, which is including 436 patients. They are exposed to have asphyxia, and they receive at least single dose of aminophylline. Based on that study and conclusion, they found single dose of aminophylline and theophylline actually helps to decrease severity of AKI and decrease the incidence and the severity. And this is the 6th trial you can see here. So you have pointer. Do you have pointer here? This, by the way. Any pointer here? No pointer? This one? Pointer? It's okay, no worry. Like you can see is okay, all the studies this is associated with, by this plot, it's less AKI. Then they look for another study with using randomized blinded placebo control study with theophylline and aminophylline, and looking for the vasomotor in neuropathy in very tame their baby with respiratory distress syndrome. They also, again, they look for the if theophylline is decreased AKI with baby with respiratory distress syndrome. And also this is a double-blinded randomized control study for babies below than 32 weeks or equal, and they have an assessed ventilation to compare with the placebo. And they're looking for 24 hours urine output at day 1, day 2, and day 5, and day 11. And they did the blood sampling for creatinine every 12 hours, and they collect the labs later on. They found, interestingly for that, the oliguria was decreased significant in these babies who received theophylline compared with control or placebo, and found the relative risk is very significant in favor of aminophylline. Also, they found serum creatinine at day 1, day 2, it was lower on caffeine group, in the theophylline group compared with the placebo. And their conclusion that the results suggest that in very tame baby with respiratory distress syndrome, early theophylline is associated or improved renal function at day 2 of life. And you can see only day 2 life they have significant, but subsequent, despite of this really lower creatinine level, but it's not reached statistically significant. Then I move now with the first study about using caffeine as exposure and risk of AKI in neonate. And this is the respective cohort study in preterm baby. And they evaluate baby with AKI below than 1,500 grams neonate, also compare with a placebo. They're looking for AKI at 10 days of life at birth and combined with kidney injury. And based on that classification, as mentioned earlier. And they found that the caffeine exposure was 72% in all patients and 54% who is received prolonged invasive respiratory support. AKI has occurred less frequently who received caffeine. And they conclude that in this cohort, very low birth weight who is exposed to caffeine is less likely to have AKI. And this is a box plot showed that caffeine group, they have lower creatinine compared with placebo. Another study also looking for association between AKI and caffeine citrate in preterm infant. This is also published on Indian journal. I believe this is from India, the study. And they're looking for the first 7 days between the baby who received preterm baby with caffeine and AKI. It is a retrospective cohort study, observation study of 100 babies and admit to intensive care unit. All babies with more than 2 serum creatinine and neonatal with death in 48 hours and less than 1 day of measured urine output from day 2 to day 7, sorry, and look for fewer 2 serum creatinine measured in this study. So they look for all the study, they found that there is 29 cases, almost 29% developed AKI in the first 7 days of life, and 9 cases developed grade 1, and the 14 cases developed grade 2, and 6 developed grade 3, according to the KDIGO guidelines. So they conclude that caffeine administration in preterm baby is associated with the reduced occurrence of severity and of AKI, and may be responsible and reasonable to consider it as routine in small babies. And this is the table just to show you that there is a statistically significant in the caffeine group with less AKI compared with the control or the placebo. And even for all the stages, also continue to be statistically significant for babies who has caffeine compared with the placebo. This is the third study for caffeine, and they try to this time looking differently, because sometimes not like to use it as most of the baby receive it caffeine. Now they look as a model of baby having necrotizing enterocolitis or spontaneous bowel perforation. It could be a good model to check the effect of caffeine and AKI. So they have reviewed all premature baby who diagnosed with NEC or SIB from 2008 to 2014, and AKI defined as the same as we defined earlier, and the caffeine was treated for apnea prematurity, and they look for the chart and review it. So they found 146 cases with NEC and SIB. They found AKI is really less frequent whose patient received caffeine compared with the received placebo, which is 55.5% compared with 92%. And when they are looking for multivariant models and adjusted for different cofactors, they found it's still statistically significant. And they conclude that caffeine exposure in preterm baby infant with NEC or SIB associated with decreased incidence of AKI in the babies who received caffeine. And again, all this is the favor of the study showed that the caffeine in favor of caffeine is the aminoglycoside, birth weight, all Apgar score in favor of caffeine group, and they have less severity of AKI. Then you can see it started to be worsening when you have using NEC, surgical NEC, vancomycin, other vasopressor, inotropic, amphotericin associated with bad outcome. So that indicates the incidence of AKI will be higher. And again, this is the plot you're looking for the creatinine, changing the serum creatinine and with caffeine and no caffeine group. And you can see it's statistically significant lower in caffeine group compared with no caffeine. So the big study actually, which is the big observational study, this is done by the AWAKEN study. And this is a really huge study. Most of the literature now focus on this, and they for a proof that they have really, there is evidence that caffeine is good for this babies. So they examined the association again, the same between caffeine group, citrate administration and AKI. The study was secondary analysis by this is organization. It's called the AWAKEN study, and is a retrospective observational study. So they look for all the patient, and they found almost 675 preterm is available to analyze. And they're looking for administration of caffeine the first week of life. And look for a primary outcome was AKI based on the notified neonatal kidney disease improving is a KDIGO as before I told you, and the hypothesized that caffeine administration would be associated with reduced AKI, and this was formulated even before the analysis, which is important. So they found it, as I mentioned, at 675, 55% they found it is male, and mean standard deviation is 28 weekers, and the mean birth weight is 1,285 plus minus 470 grams. AKI was occurred in 122 in neonate, which is almost 18.1% in the first 7 days of life. AKI occurred has frequency among neonatal who received caffeine compared with not, and this found it 50 from 475 was almost 11.2%, which is statistically significant. Even after they adjusted for multivariant, for example, and look for odds ratio, they found also AKI is less with the caffeine group. And they conclude that caffeine administration in preterm infant is associated with reduced incidence of severity of AKI, and they said maybe further studies should be done to see if this caffeine optimized is prevent AKI. But unfortunately nowadays to run randomized control study for, we know the benefit of caffeine already. It's all routine you use is not ethical to do randomized control study for 3 tiny preterm baby. But I believe between 28 and 34 weekers, it's possible you can do that, because the effect of that is not really much important compared below than 28 weekers. So again, this is AKI just to show you that the table from that big study showed still like AKI can be prevented with caffeine group, and the number need to treat is less for 4.3. Even for extreme premature baby below than 27 weeks, even decreased to 2.2. And between 28 to 32, the found number to treat 88.1. But all show that in favor of caffeine group, they have less AKI and severity of AKI compared with the placebo. Similar like this, you look for serum creatinine and the stage 1, stage 2, stage 3, and for that baby, they still be within 1 to 7 days, is still significant affected. But when they're looking between 7 days and 120, they start to lose this significant. So what to take home message for this study? So again, AKI, I'm not quite sure how you've really in your unit, but in my unit, because we have started to resuscitate 22, 23 weekers, and we are using like a lot of intensive therapy, some side effect from that. We have really significant AKI. Based on our study showed around 25% of our baby, they will have really AKI. So AKI really occurs frequently in preterm baby and associated with increased mortality and morbidity, and that's really very evident. And the study suggests that using caffeine, early caffeine administration first week of life might prevent AKI. And many studies showed that. But unfortunately, we didn't have really randomized control study to confirm it for sure, because it's not ethical anymore using this caffeine as a placebo, because we know this caffeine does have potent effect to prevent apnea prematurity. And Dr. Barbara Smith showed a big study that caffeine is the way to go for preventing apnea prematurity and decrease the BBD. So again, but also I believe suggests if there is a way we can run multi-center trial for patients with a high risk between 28 and 34 weeker or beyond with HIE, we can run, maybe give the caffeine to see if that evidence would be prevent AKI or the severity at least of AKI will be really doable. And maybe I suggested to here, I know you are very active in research, maybe it will be good things to start it because we have the population, will be a good idea to do this. And we have a really, at least we have a really maybe confirmed the result. But for sure, caffeine make a huge role decreasing the incidence of AKI. I will finish here. I'm ready to take questions and comment.
Dr. Essa, thank you very much for this presentation. Few clarifications. You mentioned in your presentation the dose is to be decided. So is there any this standard dose which is used for the apnea of prematurity is beneficial for AKI also?
Yeah.
And second thing is aminophylline is there any role? You mentioned briefly there's a study between caffeine and aminophylline comparing. these two questions.
Yeah, thank you very much. So the caffeine, all the study, because already caffeine used for prevent apnea prematurity is the same standard dose of caffeine. For example, like use a long dose of 10 milligram per kilo as a citrate, or 5 milligram per kilo as a base, and just look for the regular dose. They didn't give extra doses, and that really recommended. And now is very much it's for proof that efficiency of the caffeine. Nobody think about to give less dose or higher dose. For back to theophylline and aminophylline, I can tell you this is in before we caffeine established and widely spread. It is the only medication you use for apnea prematurity, and for sure all the study actually have more study than before. All confirm that, especially in HIE or preterm baby, theophylline and aminophylline is effective to minimize the incidence of AKI. Even furthermore, now we have running many studies, more even literature review, and we did even with the cases of HIE or established preterm baby with end stage almost renal failure or AKI, we start use aminophylline infusion on top of the caffeine, and especially with acute renal failure, and we have really very good result. We start the dose 5 milligram per kilo per hour and continuous infusion, and most of the time we avoid really end stage renal disease.
Okay, last question from my side. Is there any side effects? Now the tachycardia, jitteriness, glucose intolerance has been mentioned, but these trials has been anywhere they have mentioned about these side effects when they use for a prevention of AKI?
Again, definitely there is anything with some side effect, we know that. But again, when we talk about AKI, that's really huge for babies. That maybe the mortality and morbidity is very high. We mentioned that it's 4.8 times increase the morbidity. So we need sometimes to tolerate the effect of side effect just to prevent maybe death. So I agree there is some side effect, but for sure, I am maybe a little bit biased, but for caffeine make a huge difference for these tiny babies below than 28 weekers. But given for higher, bigger baby, maybe a big question mark here.
Thank you. Any questions from the delegates? Okay, there's no questions. Yeah, thank you.
Okay, thank you very much.
Thank you, Dr. Essa Al Awad, for sharing your views on this topic. We would also like to extend our sincere gratitude to Dr. Leslie Lewis for his contributions to this session.